Good afternoon, everyone, and welcome to the Concurrent Session 16, focused on optimizing the patient journey. My name is Jennifer Clark, Senior Director of Marketing at Innomar Strategies and Chronically Simple. We're honored to be here sponsoring the eHealth 2022, especially this subject that is so near and dear to my heart and the work that we do every day. At Innomar, we aim to enhance and simplify the patient and caregiver's journey. Chronically Simple, our healthcare management app, alleviates the administrative burden that comes with trying to effectively manage a complex or chronic illness. The secure app empowers patients and caregivers to take control of their healthcare journey, keeping all aspects of their health at their fingertips. Chronically Simple provides users with the tools to support medication tracking and education while increasing engagement, adherence, and ultimately leading to healthier outcomes. Reach out if you want to learn more about how Chronically Simple can empower and support your community. Now on to the session. This session is comprised of 4 rapid fire style presentations. If there's time for questions at the end, we will address all of those at the end of all of the presentations. You are also encouraged to connect with the speakers after the session via the virtual event platform. First up, we have Meagan Mack, Research Assistant, Digital Emergency Medicine at the University of British Columbia. Meagan, over to you.
Hello, everyone. I am Meagan. I'm a research assistant with the Department of Digital Emergency Medicine at the University of British Columbia. And today I am presenting on behalf of Dr. Kendall Ho and the Tech for Home team. The topic of my presentation today is Minding the Gap, supporting the transition of care for heart failure patients. In BC, heart failure is a major cause of morbidity and mortality. Patients with heart failure have complex care needs and are particularly at risk of becoming sick again shortly after being discharged from the hospital. According to the Canadian Institute for Health Information, 1 in 5 patients with heart failure are readmitted to acute inpatient care within 30 days of discharge. These patients could benefit greatly from additional support in the home to best manage their symptoms and to avoid further visits to the emergency department or readmissions to the hospital. Home health monitoring, which allows patients to share their health readings with healthcare professionals electronically from the comfort of their homes, offer a solution by extending professional monitoring outside of the hospital. So far, home health monitoring has demonstrated success in community care to help patients monitor and manage their health at home. This includes pre and post changes in acute care utilization, as well as improvement in self-management and quality of life. However, a key limitation in this literature is the absence of evidence on how home health monitoring can be used to support patients during their transition from the hospital back to their homes. Clinical studies to date have demonstrated promising but inconsistent findings. Moreover, implementation of home health monitoring in our current healthcare system would require the integration between acute and community care as patients transition between these 2 systems of care when they return home from the hospital. Currently, we do not have the support models and resourcing across clinical teams needed for home health monitoring to be implemented. To address these limitations, the Tech for Home Heart Failure study is designed to be a real-world research implementation, studying how home health monitoring can support the transition of heart failure patients from hospital back to their homes. The Tech for Home Heart Failure study contains 2 phases. The first phase is a feasibility study where we tested the implementation of home health monitoring as patients transition from the hospital back to home. Our evaluation framework allowed us to collect sound data, which showed encouraging trends, including a reduction of revisits to the emergency department, hospital readmissions, and overall lowered healthcare cost post-monitoring. These results are recently published in the Journal of Medical Internet Research if you're interested in reading the results. The phase 1 feasibility study helped us refine our evaluation framework and data collection strategies in preparation for the second phase of the study, which is a wedge randomized control trial. For phase 2, we scaled up and spread the research of home health monitoring through enrollment of patients from 21 hospital sites across BC. In this process, we were able to develop home health monitoring models in regional areas and also include clinical and patient-centric measures for data collection. Data for phase 2 is being analyzed at the moment, but we are excited to share our results with you and the research community when they become available. We received positive feedback from our monitoring clinicians and patient participants who indicated that home health monitoring reduced anxiety and isolation after discharge from the hospital, and patients appreciated the personalized and informed support from the comfort of their homes. We see lots of potential for home health monitoring to be incorporated into the healthcare system as a solution to support patients with conditions other than heart failure as they return home from the hospital. However, it is also important to note that home health monitoring is not a solution for every patient and condition, and research is important to identify characteristics of patients who will benefit from home health monitoring the most. As technology rapidly develops, we hope to continue to test and incorporate new and emerging home health monitoring technology so Canadians can benefit from the support home health monitoring provides from their homes. Thank you.
Thank you, Meagan. I would now like to welcome Edoye Porbeni, leader of Virtual Health New Solutions at the Fraser Health Authority. Edoye, over to you.
Thanks, Jennifer. Good morning, everyone. Joining from British Columbia, beautiful BC. I'd first like to acknowledge that the Fraser Health Authority does provide services on the traditional and unceded ancestral territories of the Coast Salish and Nipissing nations. And this territory also includes 6 Métis chartered communities. I'm also joining today from my home office in the city of Vancouver, which sits on Musqueam Nation territory. So welcome to my presentation. Today I'm going to be talking a little bit about the smart and ubiquitous technologies to support patients with dementia and their caregivers. So these statistics that are up on the screen shouldn't really be kind of surprising for anybody. We've known for several years, over a decade, that dementia is increasing here in Canada. And the estimates show that by the year 2033, we will have almost 100% or over 100% increase in the results in dementia cases in Canada. And of course, dementia patients are quite complex. Many also have lots of comorbidities, and they're taxing, let's say, on the healthcare system, both financially, but also in terms of human resources. So, the estimate right now, and I'm thinking these numbers are actually quite conservative, by 2033, adults 85 and over will show the highest growth of dementia cases at well over 100%. The issues faced by dementia patients, like I said a little bit earlier, it's not just the dementia that's presenting. There are lots of reasons why dementia patients end up in the hospital. And because they have dementia, it exacerbates their current comorbidities. So we're seeing that these particular patients are staying in the hospital a little bit longer than average. The mortality rate is higher for dementia patients in hospital compared to those without dementia, quite a bit higher. And dementia patients are frequently admitted to emergency cases for different issues, including urinary tract infections and dehydration. So again, lots of reasons why dementia patients end up in the hospital. The fact that they do have dementia just exacerbates, some of the statistics that we are seeing. So here at Fraser Health, for the last several months, we've been doing a project to develop the first virtual hospital for our organization. And the approach that we're taking is kind of a modular approach. So we're starting with the first unit, the virtual psychiatry unit that focuses on mental health and substance use patients to start off with, because the evidence in that area is quite robust in terms of virtual care, virtual health, acute virtual care services for that specific patient population. But I think everybody probably that's on this call knows that in this space, especially when we're talking about acute virtual care, many times there's not a lot out there by way of evidence. So the approach that our team is taking is we've earmarked some funding to first do research in this space of virtual acute care for dementia patients. And once we're able to complete our research, we kind of have to find our own evidence, and we see what the research tells us, what is best for these particular patient populations. Then that's going to inform the planning for the specific unit that will target these patients in the virtual hospital. The idea, of course, is to improve quality of life, to decrease length of stay, to improve the overall well-being of these patients. And if we can keep them in a safer environment rather than having them come to a bricks and mortar hospital, that's what we would like to do. But the first step is the research. And then the second step is the strategic planning, design sessions that have many stakeholders involved, but the key ones being the FAN, so that's family and natural supports, especially those of who have relatives or loved ones who are suffering from dementia. Identifying the appropriate virtual health technologies for this specific population, it's a little bit more involved, right? There's a little bit more that you need to consider when you're selecting the appropriate technology. Identifying the proper care delivery model and the staffing models, of course, to support these particular patients and their family and natural supports. And then, of course, we would develop the workflows and go on to implementing and establishing the unit for this particular patient population. It's exciting times here in our health authority. The virtual hospital is an ambitious undertaking, to say the least, but it's something that we know is absolutely needed in one form or another moving forward in healthcare here in BC, and I think across Canada and the world. Thank you all for listening.
Thank you so much, Edoye. Those statistics are definitely quite telling and a cause for a pause and a change. So thank you again for everything that you highlighted. Next to the virtual stage, we welcome Nina Gregoire, a PhD student from the University of British Columbia. Nina, over to you.
Hi, hello everyone. So our presentation is entitled Understanding Chronic Pain Waitlist Experiences to Facilitate Need-Based eHealth Platforms. My name is Nina Gregoire, and I'll be walking you through our study. And just a quick note that this research was conducted at UBC and Bill Nelms Pain and Research Center in collaboration with Thrive Health and was funded by MyTax. And this study took place on the unceded territory of the Syilx people. Whoops, sorry. Okay. So the healthcare challenge that we addressed as part of this study was understanding the experiences of patients who are waiting for specialist pain services. As we're all aware, wait times to see specialists in Canada can be lengthy, and pain care is no exception to this. The median wait time for publicly funded interdisciplinary pain clinics is 5.5 months. So previous studies have found that many people who are waitlisted for pain services experience significant deteriorations in psychological well-being and their health-related quality of life. So despite the overall effectiveness of interdisciplinary pain clinics, not all patients will experience treatment success. For example, interdisciplinary pain clinics are prone to high attrition rates, and this is partially due to the psychological decline that occurs while people are on the wait list. eHealth technologies have been found to be helpful across multiple domains. So for example, apps targeting anxiety have been found to help reduce this negative state, and the online delivery of pain education classes have demonstrated a reduction in psychological constructs that contribute to patient suffering. So our study explores the experiences of a subset of patients with chronic pain, specifically those who have been waitlisted, to help determine which technological features on a web-based platform they think would be useful to them during their wait. So in this study, we asked 200 participants who are patients at a pain clinic located in Kelowna, BC, about their waitlist experiences. 59% of the participants indicated that their overall well-being deteriorated. 36% endorsed no change in their overall well-being, and 5% noted an improvement in their overall well-being. The pain experiences they reported on the waitlist included low control over their pain and high pain intensity. In other words, on average, patients felt that on a scale from 1 to 10, their level of control was a 3, and their intensity was a 7 while they were on the waitlist. In our study, over half of the sample was unable to access many of the services that they wished to in order to manage their pain while they were waitlisted. The barriers participants most commonly faced when accessing pain services while waitlisted were related to the cost of services simply being unaffordable to them, their pain being too severe and being too fatigued to seek out and participate in services. So one possible solution is to create a web-based platform to help patients along their journey. To do so requires input from patients in order to solicit preferred features for an online waitlist platform. So the most popular feature that was identified in this sample was self-management tools. This was closely followed by pain education and tips and information about supplemental services. And next was having the platform connected to their provider and the ability to flag notes to their providers. So when creating a platform, it's really helpful to understand what patients themselves feel is useful and relevant to them, and then identifying the emotional states, barriers, and needs of chronic pain patients may be useful in creating a platform that supports their overall well-being. Such a platform may reduce deterioration, give patients feeling of more control over their pain, and possibly provide strategies for decreasing pain intensity during the waitlist period, thereby increasing their patient success. Further, such a platform may help improve access to care for those with chronic pain by providing them with no to low cost tools that they can use at their convenience. So those times when their pain is lower and they're not fatigued, and can also help them find things that are available to them in their community, thereby reducing their patient burden. And so that's everything I have. Thank you very much.
Thank you, Nina. We do know that chronic pain can affect all aspects of patient lives, and it's very exciting to see innovations in this area. Can we move to the next slide? Our final presentation of the session is brought to us by Tricia Menio, Clinical Leader of Virtual Health at the Provincial Health Services Authority. Over to you.
Thank you, Jennifer. It seems that we have a theme of West Coast presenters here, so pleased to be in this space. Good afternoon and good morning to some, as it is still morning here on the West Coast. As Jennifer mentioned, my name is Tricia Menio. I'm a clinical leader with the Office of Virtual Health in the Provincial Health Services Authority organization. 1 second. Perfect. I'm calling in from my home in Delta, British Columbia, and acknowledge that I work, live, and play on the shared traditional, ancestral, and unceded territories of the Tawasin, Musqueam, and other Coast Salish peoples, extending the appreciation to these First Nations for the opportunity to present to you all today from. So today I'm going to share with you how we amplified communication through clinical digital messaging, or in other words, texting. The literature shows that text messages increases efficacy in appointment attendance and behavior changes to positive health outcomes. The call to action for clinical digital messaging is grounded in the unifying goal to provide easy to use, accessible tools for patients to connect with their clinical team. So our challenge, we needed to augment the communication, essentially elevate the existing channels to connect with these patients. We needed to make it easier for patients to connect with their clinical team and provide support to patients in attending their appointments. We did this, and we needed to do this by automating reminders to be sent to their phones, such as a reminder to complete their blood work prior to their appointments. As well, we needed to just connect with these patients and provide this service as I'll allude to my barriers that a lot of the challenges were from an increase in cancellation and no-shows. And then lastly, we needed to address the workflow inefficiencies. This program has previously used phones to text message their patients, and we needed just to elevate the way that they were connecting with their patients. So some of the barriers we encountered as we paired with the program to launch this initiative is the insurmountable task of moving and automatically populating the data from the existing electronic medical record into a new texting system. As well, the relationships between patients and healthcare teams were tenuous at times, and we needed a system that would not disrupt these connections. So there was challenges in designing a flow that allowed for easy, comfortable conversations through texting. Along with this was the challenge in preserving patients' privacy and confidentiality. Sensitive, often uncomfortable information was shared generally, and we needed to design messages that were concise and easily received. And then lastly was managing all the change management pieces with launching a new virtual initiative. Texting was not new to the program, and naturally having a centralized texting solution was well received from the team. So our solution, as I alluded to, we supported the program in launching and incorporating a clinical digital messaging solution that enabled smoother conversations via text messaging and the ability to automatically send out appointment and blood work reminders. An additional feature that was enabled was the natural language processor, also referred to AI, or in this case, named Felix. So this processor allowed for text messages from the patients to flow and essentially a survey to respond and help them through their questions, such as pre-screening questions for COVID-19 prior to their in-person appointments. So we happily to report that we've successfully completed 2 pilots of clinical digital messaging, and we are now into the evaluation phase. Patients and clinicians were surveyed about their experience, as well as quantitative data was collected from the solution. So as you can see, some of the results I have shared here on the screen is that patients have had positive experiences with texting. And particularly one response that stands out to me is that 90% of patients would recommend texting to others. So this just shows it further amplifies the need to embed texting into future state workflows. And that takes me to the end of my presentation. Thank you very much.
Excellent. Thank you, Tricia. And thank you, everyone, for your very interesting presentations. There's definitely a theme of meeting patients where they are, ultimately looking to improve the patient experience or fill a gap that is currently that they're experiencing in their healthcare journey. So I really appreciate the problem solution approach that was illustrated here. So I will have a look at the Q&A. We do have one question, Tricia, that is directed towards you, and that is the texting in English only, or is there language variability there?
Yeah, great question. Thank you. At the moment, for the scope of these 2 pilots, they were just in English. But as we move forward to operationalize this, that is definitely on our minds of consideration. Thank you.
And then a follow-up question for you. You're on the spot. So there's a question here about whether there were any guidelines set for texting with patients. And I think you alluded to that with some of the compliance and privacy regulations.
Yeah. That's a great question. Guidelines and policy, again, is also at the top of our list when we have these discussions, particularly with the sensitive information that we're sharing through text messaging or can be perceived as sensitive information. And happy to connect offline. But yeah, these pilots are not directly informing or shaping the policies, but there is parallel work that's being done with revamping the organizational policy on text messaging, as well as the internal program policies on text messaging.
Excellent. And to take some of the pressure off of you, Tricia, I would love to hear from each of the speakers, as we're kind of heading into 2023, and I know it's weird to say because we're still in the spring, but everyone's looking forward to their innovation plans and things like that. What is the one thing that excites you most when in the next 1 to 2 years? Meagan, did you want to start first?
For our study, currently we're actually extending the home health monitoring service to patients with other conditions like hypertension and stroke. And that is very exciting for us because I saw how we went from heart failure, which is like, we call it the OG here, and we are extending it to other conditions and how like other patients can also benefit from it. And obviously seeing it get bigger and receiving more positive feedback is very exciting for us to continue to like modify our whole like framework and like look at the new technology. Like phones are capable of doing so much now, like Apple Watches. I work in the ER and we see patients coming in when they get like an alert on their Apple Watch that their parents like had a fall from home, and like they just know that there's something going on. Like all of that is very exciting updates and tech just coming in to help us all.
Excellent. Thank you. Edoye, did you want to go next?
Sure. I think what I'm most excited about is a slowdown in a way, but I think something that is purposeful and deliberate, because with COVID, we all kind of were rushing to get virtual technologies and virtual solutions out. And we didn't always have time to involve patients the way that we should. And I think over the next couple of years, we're slowing down because, there's not that frenzy anymore. And in that slowdown, it's going to give us the space to really involve patients and, different stakeholders in the design and acquisition of these new virtual technologies. And that, everybody on this call knows that is integral to adoption and sustainability. And it's just the way, it's best practice, right? In the way that we should be doing things. So I'm really looking forward to seeing more of that.
Very exciting. Nina, over to you.
Thank you. Yeah, similar to Edoye, just the integration of what we've learned from the patients. So with this study, we're planning on now launching a kind of beta version of this and testing it and doing kind of some pre-post and evaluating if people have changed on that readiness to change type model, and depression, anxiety, pain interference, maybe some treatment expectancies. So just trying to understand how we can be impactful for folks with chronic pain is really all that matters in this research, is making those gains and doing right by them. So that's the next steps, and I'm very excited to be part of it with Thrive Health.
Excellent. Tricia, last thoughts?
Hi, thank you. I echo a lot of what everyone has already said, and as well, I'm most excited for the possible integration into the other EMRs or some of the provincial systems that we have set up, and just I'm looking forward to that, sort of one-stop shop where we can go and just connect with our patients all very seamlessly.
Excellent.
Thank you.
Okay, well, we are coming up to the end of the session. So again, thank you everyone for joining the panel and for your fantastic presentations. An exciting discussion at the end here. Next, I would like to invite all attendees to join the exhibitors for networking and discussions in the virtual trade show. So you can access that trade show at the top of your screen and look forward to seeing you all there. Thank you, everyone.